So good morning, everybody. Hello? Everybody's still there? Excellent. It's really nice to see all of you here, and I want to thank Dr. Patel, Dr. Jethwani, and Dr. Moore for these really fabulous presentations, and to tell you what an honor and a pleasure it is for me to provide some comments on these three presentations. So I think there are three common themes that I would like to emphasize that I believe are woven through the presentations. And the first is the absolutely gaping need for service delivery in mental health, the opportunity for digital health to begin to breach this gap, and then finally the need to actually design the interventions for the patients, the individuals themselves, for the providers, the people delivering the care, and then for the health systems, as you heard Dr. Patel, insofar as health systems exist in the world. So the first theme I just really want to emphasize again is this documentation of the wide gap. In fact, it's not just a gap, it's a gaping hole, or I might even say it's a chasm. It's actually as wide as the Grand Canyon. I am not actually going to speak from any slides, but the one slide I thought last night about putting up there is a picture of the Grand Canyon, because I wanted to have you think about leaping across it and what that might feel like, and to really represent that that's actually the challenge that we all face in actually trying to figure out how we are going to meet this unmet need in mental health care across the spectrum of prevention, early intervention, detection, treatment, recovery, community engagement, and wellness, compared with the ability for any country, whether low, middle, or high income, to deliver or provide that care. And I think the statistics are just really stunning, and I am going to spend a couple of minutes on them because I think this is one of the places where globally we actually really come together. About 25% or so of adults are going to meet the criteria for mental health disorder annually in the United States. From Dr. Moore, he presented some data which I don't think you were able to see because he needed to move on to all the other information he had. But 90 million Americans live in federally designated mental health professional shortage areas. 90 million Americans, compared with 55 million for primary care and 45 million for dentistry. Globally, there's been a 50% increase in the global burden of mental health and substance use disorders in the past 25 years, accounting for 1 in every 10 years of lost health. The percent of total spending on mental health is strikingly low, but what is even more striking to me is that the minimal spending and spending disparity compared with general health care exists across low, middle, and high-income countries. And also striking are the rates of minimally effective treatment coverage for substance use disorders, anxiety, and depression, the three most common of all the mental disorders. And in low and middle-income countries, the rates of minimally effective treatment range from 1 to 4% for those three disorders. In high-income countries, the range only is between 10 and 22%. What that means is in our best-case scenario in the world, the rate of minimally effective treatment coverage in high-income countries is for depression, and it's only 22%, and then it goes downhill from there. So we have a giant unmet global need, the Grand Canyon, the chasm. So that said, I think the other theme that you've heard woven through all three of our presentations here today is the major opportunity to address many aspects of this need through digital technology, coupled with an explosion of interest and investment across a wide range of technologies proposed, those in use, and those being tested to meet these needs. Now, Dr. Patel told us that across more than 20 countries, studies have targeted the use of technology in 5 areas: supporting the training of health workers, facilitating diagnosis and detection of mental disorders, promoting treatment adherence and supporting recovery, self-help programs, and substance use prevention and treatment. He also highlighted in more depth projects he and his team are implementing in India. These fall in 3 critical areas: building a workforce, delivering the interventions, engaging the public. And one critical idea that he highlighted, and I think then was emphasized also by Dr. Jethwani and Dr. Moore, is this need to develop interventions with the input of the users or the people for whom these are being designed, the actual interaction with the stakeholders themselves. And one thing he presented in just a couple of minutes, but I think it's really an important one, is in developing these scalable self-help games for adolescents in low-resource schools to improve their mental health by learning and practicing problem solving. His team is co-designing those interventions with the adolescents and developing them through an iterative process. This is very important, I think, and this actually begins to develop something that is actually for and with the individual. I think this engagement with stakeholders or the target population is critical and is a third theme woven and emphasized through all three presentations. I think the scope of what we actually mean by delivery of interventions was expanded on by Dr. Jethwani and Dr. Moore. Dr. Jethwani presented the design of digital health innovations in the context of a large health system, Partners Healthcare here in Massachusetts. And his presentation expanded upon and refined what we mean when we talk about delivering interventions. For instance, for mental health, digital technology is utilized to replicate and extend what we mean by a patient-provider interaction and also by a provider-provider interaction for online consultation. But beyond that, delivering interventions also encompasses patient self-management, including integrating into care, patient wearables and health apps, and consumer devices for tracking fitness, sleep, and other behaviors. This can extend what we mean by delivery of interventions in mental health beyond a specific behavioral treatment, for example, CBT, to patient self-monitoring for symptoms and behaviors. And with that, I'm just going to digress for one moment because I've been texting with my husband to get his permission to divulge personal health information, or PHI, which is that he was an early adopter of the Spire, and he is now 4 years out in using the Spire, not combined with the Muse. But I was very interested in the data on the Spire, and he reminded me to say to you that he actually really started off with the Spire to learn to track his breathing, for deep breathing. And what he's been fascinated by across 4 years now, uses it every day, is that by monitoring his breathing, it tells him all day long whether he's tense, concentrating, or relaxed. And he cannot believe that by monitoring his breathing, the thing is so completely accurate about whether he's tense, stressed, relaxed, or concentrating. It's remarkable. And he has learned through that, it tells him, take a deep breath, which he does. Deep breath, and it's helpful. So anyway, I just wanted to say that's an early adopter, and he's way outside your bell curve there about use. It's beyond 12 weeks, and so it's very interesting because what we measure is only what we measure, but we don't really know for sure exactly how users are using these technologies. And I just wanted to digress there because I think it's pretty interesting. So Dr. Moore then presented how to design interventions for patients and for the healthcare system. In this instance, he has the opportunity to engage with Northwestern Medicine Physician Network, and in his slides, he actually described that that's 1.5 million patients, 3,000 physicians, with wait lists for mental health treatments of 4 to 6 months, and in some instances, zero availability. And so in taking on building that out, he described that there is, in fact, a research to practice gap, that in fact, there's a lot of efficacy testing of taking interventions that we know worked in person, putting them on a new platform, and then we see the efficacy. But where we failed is in this effectiveness, translating it into systems. And what he talked about is how he's developed the IntelliCare suite of apps and emphasized the need to understand what technology people are using and how they actually use it. Again, hearkening back, I think, to the comments that Dr. Patel used in terms of talking about working with adolescents, for example, to understand what they need and what they want and how to use it and how to design it. The IntelliCare suite of apps for depression, anxiety, and social isolation and sleep uses elemental designs. People can pick and choose skills-based apps that are eclectic. And Dr. Moore provided, I think, some more sage advice on app design, including designing for what the user will use and wants to use, Simpler is better. Messages are highly rated by users but need to be personalized. Information is valued, but it needs to be short. Text messaging is liked by users, and checklists are liked by users, but personalization is very important. I am absolutely fascinated by the skeuomorph. I'm going to think more about that and what that actually means for us going forward. So we've heard about the gaping need for mental health care across the entire spectrum, from wellness to prevention to early detection to intervention, adherence, recovery, community integration, and the many promising ways across countries, disorders, and health systems digital technology can help us bridge this wide chasm of need and be deployed for public education, workforce training, screening for illnesses, engagement and treatment, treatment delivery, self-monitoring by individuals, online interactions with clinicians, and more. So I have some questions that I'm really interested in as we move into this world of digital mental health, which, is not anymore a maybe do that. It's actually a given that we must do that. It's an imperative given the vast chasm of need that we have. So what treatment or elements of treatment can we and do we need to deliver? To whom, for what, for which symptoms, which behaviors, which disorders? How can we integrate these into healthcare that's in person or our clinical in-person care system? What are the cultural contexts for these interventions, and how do we take these into account? Dr. Patel was mentioning language, very important, in addition to culture. How do we explore and account for, one thing we didn't talk about, gender differences in technology preferences and effectiveness, and there is a growing literature on gender differences here. How do we know the best way to prioritize our investments in this area? What's the best way to do that? For example, is it for wellness? Is it for education for either the individual, the public, or the clinician, practitioner, or healthcare worker? How do we use it in conjunction with the health system? What about for early identification, early intervention, follow-up post-acutely, community reintegration, monitoring of systems, other forms of data collection? Where do we put the investment? How do we prioritize? And then for all of the above, how do we actually test for quality and outcomes of the interventions that we're actually trying to deliver to help people with a wide array of need across the entire world? So with that, I again want to thank our three remarkable presenters today for all three of these engaging and important presentations, and I want to turn the podium over to Dr. Leary. Thank you.